Intestinal tuberculosis is a chronic infectious disease caused by Mycobacterium tuberculosis. It primarily affects the intestines. This video will explore various aspects of the disease, including diagnosis, treatment, complications, and management strategies, aimed at providing comprehensive knowledge to medical students. Intestinal tuberculosis is characterized by cas-eating granulomas and epithelioid cell aggregates. Granulomas can be found in all layers of the intestine and are indicative of intestinal tuberculosis when observed in biopsy specimens. Radiological imaging is important for diagnosing and understanding intestinal tuberculosis. Common findings include thickening of the ileocecal region, strictures, lymphadenopathy, and ulcers. CT scans show concentric rings or target lesions in the intestines, while chronic inflammation can lead to bowel blockages. Lymph node involvement helps differentiate from other GI conditions. Gastrointestinal tuberculosis and pulmonary tuberculosis differ in their clinical presentations, diagnostic techniques, and management. Gastrointestinal tuberculosis presents with abdominal symptoms, while pulmonary tuberculosis is characterized by respiratory symptoms. Diagnosis of gastrointestinal tuberculosis is challenging, often leading to delay or misdiagnosis. Treatment duration for gastrointestinal tuberculosis is longer due to its chronic nature and specific challenges. The diagnosis of intestinal tuberculosis can be arduous and often delayed due to several challenges. The symptoms of intestinal tuberculosis, such as abdominal pain, diarrhea, and weight loss, can mimic various other gastrointestinal disorders, including Crohn's disease and malignancies. The lack of specific symptoms and the limitations of diagnostic tests further add to the diagnostic challenges. Conventional diagnostic methods, such as acid-fast bacilli staining and culture of biopsy specimens, have suboptimal sensitivities and specificities. This necessitates the utilization of complementary investigations, including molecular techniques like polymerase chain reaction, PCR, for improved diagnostic accuracy. Endoscopy plays a pivotal role in both the diagnosis and monitoring of intestinal tuberculosis. The endoscopic features seen in intestinal tuberculosis include ulcerations, nodularity, and cobblestoning. Ulcerations, often shallow and punched out, are usually multiple and may have an irregular and undermined base. Nodularity refers to the presence of raised lesions resembling small nodules or polyps on the mucosal surface. Cobblestoning, characterized by a cobblestone-like appearance due to inflamed and edematous mucosa interspersed with normal-looking areas, is another hallmark finding. The evaluation of these endoscopic features, combined with histopathological findings, aids in establishing the diagnosis of intestinal tuberculosis. Histopathological analysis of intestinal biopsy samples is essential for diagnosing intestinal tuberculosis. Granulomas, characterized by a central core of necrotic material surrounded by cells like histiocytes, lymphocytes, and giant cells, are key in evaluating the tissues. The immune response involves T lymphocytes and cytokines like interferon gamma, which maintain granuloma formation. Caseation necrosis and granulomas in biopsies strongly indicate intestinal tuberculosis. The pharmacokinetic properties of anti-tuberculosis drugs are essential for understanding their efficacy and potential side effects. The primary drugs used in the treatment of intestinal tuberculosis include isoniazid, rifampicin, pyrazinamide, and ethambutol. These drugs undergo absorption from the gastrointestinal tract and subsequent distribution to various body tissues, including the site of infection in the intestines. The metabolism of these drugs occurs predominantly in the liver, where they undergo biotransformation before elimination through the kidneys. Understanding the pharmacokinetics of these drugs helps optimize dosing regimens and minimize drug interactions. Intestinal tuberculosis can exhibit manifestations in organs beyond the gastrointestinal tract. Lymph nodes, particularly the mesenteric lymph nodes supplied by the affected intestines, are frequently involved. Lymphadenopathy, often characterized by cas-eating granulomas, can lead to the enlargement of these nodes, which may be palpable on physical examination. Peritoneal involvement, known as tuberculous peritonitis, can result in ascites, abdominal pain, and constitutional symptoms. Liver involvement, albeit rare, can manifest as hepatic granulomas, leading to hepatomegaly and abnormal liver function tests. Recognition and appropriate management of these extraintestinal manifestations are crucial for optimal patient care. In recent years, molecular diagnostic techniques, such as polymerase chain reaction, PCR, have become invaluable tools for the diagnosis of intestinal tuberculosis. PCR allows the detection of Mycobacterium tuberculosis DNA directly from clinical specimens, such as biopsy samples or body fluids, with high sensitivity and specificity. This technique overcomes the limitations of traditional diagnostic methods and offers rapid and accurate results. Additionally, PCR can detect drug resistance markers, aiding in the selection of appropriate anti-tuberculosis therapy. Despite its advantages, PCR should be used as an adjunct to clinical evaluation and histopathology for a comprehensive diagnosis. The immune response in intestinal tuberculosis is complex and involves T cells, macrophages, and cytokines. T cells recognize mycobacterial antigens, cytokines regulate the immune response, and macrophages help contain the infection. Modulating the immune response is crucial in managing intestinal tuberculosis. Surgical intervention may be necessary in intestinal tuberculosis to manage complications like strictures and perforation. Strictures may require stricturoplasty, bowel resection, or stoma formation. Perforation necessitates immediate surgery. Decisions should be made collaboratively, considering the patient's condition and disease extent. Intestinal tuberculosis treatment adherence is challenging due to the long duration of therapy and associated side effects. Socioeconomic factors further impact adherence. A comprehensive approach including education, counseling, and support networks is essential for optimal outcomes. Intestinal tuberculosis is a challenging disease to diagnose and manage. Medical students must comprehend its various aspects, from pathology to treatment adherence. By understanding these nuances, we can enhance patient care and improve outcomes.